try. So. All right, thanks everybody. So yes, if you know anybody who wanted to see LARPAR, not pancreas, feel free to tell them. In the book, it's incorrect. It's the old talk, pancreatic surgery, and we changed it last minute to LARPAR. So I think in the app it's correct, but in the book it's incorrect. So feel free to pass the word around. But we talk about LARPAR. We can talk about anything you want, whatever you want. We can talk about. So I'm Dr. Shadia Rayfitch. I'm a boarded surgeon, and this is laryngeal paralysis. A little bit about me, if you don't know, I graduated from Cornell University in 2006. 1-year internship at Angel in Boston, where I did my general internship, and then I went to Long Island Veterinary Specialist for 2 1-year surgical internships, stayed there as a resident, and then moved out west to Las Vegas, performed surgery at a specialty hospital in Las Vegas for about 9 months, then flew around the country for doing locum work. After that, I was a surgeon for 3 locations at United in Silicon Valley. I was on call 24/7. And then I continued my on-call 24/7 at TrueCare in Studio City. I was one of the owners of the facility. And then I left and then started Vet Triage at the end of 2019, which is a virtual platform. If anybody's interested in talking more about it, I'm more than happy to. And this will be laryngeal paralysis. The preceding notes, I'm not just sure if you have the preceding notes, because originally the talk was a pancreatic talk. So if you ask dvm360 for the notes, I'm happy to forward them along. But if you do have the notes, or when you get the proceedings, what's that?
They're in the app.
They're in the app. Nice, good. So those proceedings are crazy detailed compared to what we're going to go into. That's a whole bunch of literature that I've summarized in there. And this is meant to be more practical, clinical, that you can use in your day-to-day for LARPAR. So we'll talk about brief anatomy, types, clinical signs, causes of it, diagnostics, management, and post-op. Any questions you have, feel free to interrupt at any time. How many folks here cut laryngeal paralysis cases? Okay, all right. So you refer them in typically? You diagnose them if the owner wants surgery, I guess. How many folks here medically manage LARPARs? Yeah, it's common. Yep. Okay, good. Yeah, so it's one of those surgeries where you could perform as a general practitioner. I would suggest for sure trying it on cadavers first, and that way you get the anatomy right. Obviously, there won't be any bleeding with the cadaver, which is part of the struggle here, because a lot of these dogs are going to be large breed, old dogs with very meaty necks. So the dissection it can be very complicated. But if you're able to maybe get 2 or 3 cadavers in practice, it is a procedure you can perform, especially for somebody who can't afford a surgeon or there's no access to surgeons in the area, and they trust you, and you're like, hey, look, I'll give it a shot if you want me to. I've only done on cadavers or whatever, and it's something that you can actually perform with a tie-back surgery. So it doesn't have to be before a surgeon, but it's a matter of getting the anatomy down, and the anatomy, the dissection to get that anatomy can be very annoying for these dogs. So that's the challenge that you have with these, typically with surgery. The anatomy is important because it ties into the pathogenesis of the disease. When you think about laryngeal paralysis, everybody talks about it being idiopathic, which to some degree, that's pretty much what we call it. But in theory, if you have laryngeal paralysis in a dog, and you can see in cats too, but this is far more common in dogs, so we'll stick with dogs. Really, a lesion anywhere along the pathway that starts from the brain and goes to the laryngeal cartilages can cause laryngeal paralysis. It is a neurodegeneration disorder and a low neuron neuromuscular disease. And so theoretically, any lesion anywhere in this pathway can cause it. So right from where the beginning of the vagus nerve and the nucleus ambiguous, the vagus nerve itself, and then as it turns into the recurrent laryngeal nerve, innervating the cricoretinoideus dorsalis muscle, which controls function of laryngeal cartilages. You have a problem anywhere along this line, you can theoretically have laryngeal paralysis. So in theory, if that's true, it would be great if every single LARPAR dog had a full neuro workup as well, including a brain MRI to make sure, to look at the pathway of the vagus nerve and see if there's a lesion anywhere there. We don't typically do that. I never have myself, even though I have access to MRI. Typically these are dogs that just need immediate surgery if they're that bad off, and you're going to perform your basic diagnostics that we'll go over, and then you go into surgery, and that's it, it's a done deal. So we typically don't perform the neurologic workup that they probably require, and so usually in veterinary medicine, when we have things like that, we call it idiopathic because we don't have a reason for it, but we haven't really looked, in my opinion, on it. Now there are more papers coming out that are finding that dogs that do get at least a complete neurologic examination, they almost 100% have some sort of neurologic deficits in their examination. And so whether that's because they're all dogs, maybe they have low-grade degenerative myopathy, or they have arthritis that's affecting the nerve transmission, or maybe they do have a neurologic disorder, but still, we are hopefully will get more studies to continuously confirm and shed light onto this, because it's a common condition, and I really can't stand calling things idiopathic until we truly looked at all the reasons. So keep that in mind too. Any lesion in the pathway of this nerve is going to cause this disease, or an issue with the muscle, or an issue with cartilages can cause laryngeal paralysis. And so this is just an example of the recurrent laryngeal nerve. So you have the vagus nerve coming down and then branches off here before going down to the chest cavity and abdomen. The recurrent laryngeal nerve then go ahead and innervates the cricoid dorsalis muscle that is going to be sitting on top of the arytenoid cartilage, and it controls the laryngeal function. There's another picture of the recurrent laryngeal nerve here, and then you have this is meant to show the complexity of the nervous system in the thoracic cavity. But then I believe this is the vagus nerve here, because once it goes towards this esophagus, it splits into dorsal and ventral branches, and then goes to the hiatus and then into the abdomen. But just to prove the point that it's complex in terms of the innervation of where the lesion could be affecting these dogs and causing laryngeal paralysis. Now we do think of it mostly as an acquired condition, which is the most common, of course. I have seen it in some dogs, congenital, and usually you see it less than a year of age. And I'm actually surprised at this incidence. To me, I would think it's even lower than that, but apparently it's a 20 to 30% incidence of congenital LAR-PAR, and here are the breeds. And then most of us, and maybe all of us now, will consider it some part of a polyneuropathy complex. So laryngeal paralysis polyneuropathy complex, that's the phrase that we're trying to use to depict that this has a neurologic component to it. This is in reference to congenital disease, but again, the neuropathy portion of it is probably in the acquired version as well. And the prognosis tends to be poor with congenital laryngeal paralysis, although the very few that I have repaired have done well. But to me, and if anybody knows different, let me know. They're still surgical cases, even if they're congenital. It's just a matter of, can that dog wait longer to mature more? Because one of the concerns I have with a congenital LAR-PAR is that the cartilages aren't going to be as strong as an adult dog, right? And so if you fracture the cartilage, you can always do the other side as a backup plan, but you prefer not to if you can avoid it. So, and I don't have any information on how young is too young, how long can you wait. To me, it's like wait as long as you can to get the cartilages more mature, but that's about the extent of it. I have minimal experience with congenital, and how many people here have seen congenital LAR-PAR in dogs? Yeah. What did you do for that case? Do you remember?
Oh, I mean, the surgeons did do the
surgery,
but it broke down after a couple of years, and we saw the dog for pneumonia. He really didn't want to do the other side, but so yeah. I mean, I guess just live longer. So I don't know. The surgery just doesn't last forever.
Yeah, when you perform this surgery in older dogs, they're not going to live that much longer, right? And so you kind of expect your tieback to last the life of the dog. It's kind of a total hip replacement. Now that we're seeing them in younger and younger animals, you're going to start seeing total hips that need to be replaced as the patient gets older, just like you do in people. I think every 10 years maybe you have to replace a hip, and because we're going to live to 80, 90 plus years old, so the dogs don't. And so we'll see more things like that as we continue to perform procedures in younger animals. And then with the acquired disease, it's a longer name, but still polyneuropathy. It tends to be more insidious in its progression. These are dogs that have loud breathing for months, but usually years, and it's progressive over time. Some dogs, they just live with it, and some dogs progress to the point where they have an upper respiratory obstruction. It just depends. and it's the characteristic clinical sign is inspiratory stridor. It's typically older dogs. It seems to be a predilection towards males. Large breed dogs are primarily affected, labs, rotties, but any large breed dog can develop laryngeal paralysis. I have seen it in smaller dogs like Cavalier King Charles Spaniels. I saw it in one or two of them. I can't remember other ones, but it's a large dog disease. And so this is it's classic neck stretched out. Dog is trying to suck in air because it has upper airway obstruction from laryngeal paralysis. And typically with dogs that have are that clinical for it, most of them have bilateral LARPAR. It usually starts off, we think, with maybe unilateral, or maybe it's bilateral, but it's more paresis, weakness of the vocal cords. So maybe they're just loud breathing and that's it. Once you get bilateral, full-on paralysis, they're clinical for it, but it depends on the dog, of course. But there is some progression with that. Now, hypothyroidism is always a common association with this condition. So we do see hypothyroidism in large breed older dogs anyway. And so, is there a causality there? Is it just happenstance? 50% of dogs with LARPAR have hypothyroidism. You can supplement these dogs with hypothyroidism, but you're not going to reverse the LARPAR. So it's not a treatment modality for laryngeal paralysis. So you treat the hypothyroidism because you're obligated to, or whatever, use your clinical judgment. I'm out of the world of treating that condition, but use whatever standards you have. But it's not going to reverse the laryngeal paralysis if they have hypothyroidism. And they can still develop, if they have laryngeal paralysis without hypothyroidism, they can still develop hypothyroidism later on, right? So who knows if it's related or not. Because again, when you're treating laryngeal paralysis, you're not treating the underlying cause. It's symptomatic treatment, right? So keep that in mind too. You're not fixing the problem. That's just like blocked cats. We perform a perineal urethrostomy in blocked cats, urinary obstruction, male cats, but that's not fixing the underlying issue. They have something else going on. We're doing this to prevent an emergency. And so same thing here. You treat LARPAR, you're not fixing anything, and so if permanently, like foundational, and so these dogs that have hypothyroidism, whether you treat the LARPAR first or thyroid first, it doesn't matter. It's not going to affect the other one. So who knows? There's just an association or causality there. You can see rarely in dogs a hypothyroid polyneuropathy. And lots of endocrine diseases can result in a polyneuropathy. So this is not common, and so I don't know whether or not treating the thyroid in this condition would reverse it or not. But anyway, most pets, it just seems to be an association there. Whether there's causality, I don't really know. So neuromuscular disease, like we've already mentioned, very common, and I'm sure a lot of these dogs, it's underdiagnosed. It must be underdiagnosed, and we'll see more data on that. So if they have laryngeal paralysis and they have neuromuscular disease, they're at a 21 times risk of developing megaesophagus. So that's substantial. If they have megaesophagus, you will find laryngeal paralysis in almost 12% of cases. Interesting. If they have neuromuscular disease, that makes up to 22 to 56% of laryngeal paralysis cases. And if there's pre-op neuromuscular disease, then 10 to 28% and up to 100% 1 year post-op will develop laryngeal paralysis. So these are striking numbers, and again, the point is to keep it in the back of your mind. It may not change how you manage these conditions. It may not change what the surgeon does when you refer the case to them, but if you're going to stage the dogs, keep that in mind. A full neurologic examination to the best of your ability, and then looking for things like megaesophagus, even if they're not clinical for it. And anyway, you probably ought to be performing 3-view chest rads on these dogs for metastatic screening, to look for bronchopneumonia, any other concurrent diseases, and so hopefully, if they have megaesophagus, you'll catch it on the films. But on digital x-rays, I don't know if anybody does film anymore. So keep that in mind, very important. Laryngoscopy is, of course, the diagnostic test of choice to confirm laryngeal paralysis. It's very accurate, and there are studies of performing laryngoscopy via the nasal cavity if you do scopings. Otherwise, most of us are going to perform an oral examination and try and diagnose it that way. So there can be some subjectivity when you're performing performing a laryngeal examination, right? Because you have some dogs, if they're too deeply sedated, they may not move that much, right? And you have other dogs.
Road closed in 59 miles. Your route
have like a fluttering going on, so is that LARPAR and just from their breathing, it's just causing these flimsy vocal cords to move, or is that a dog that's just like too sedated and we have to wake them up more? So it may take some practice to be accurate with this. The more awake the dog is, the more likely you are to believe what you're seeing, that it's actually paralyzed or not, and if is it paralyzed or is it paretic, is it unilateral, is it bilateral? That's what you're trying to figure out. And of course you want to rule out any like laryngeal masses or something. You could have the case where you think it's idiopathic LARPAR, and then you find there's like a laryngeal mass or something there, so keep that in mind too. So we can grade the functionality of the vocal cords when you're looking at these dogs under laryngoscopy. So here are the grades. 0 or 1 is normal. 2 is it's asynchronous, but you get full abduction. 3 asynchronous, incomplete abduction, and 4 is marked asymmetry with no movement or complete paralysis. Again, there may be some subjectivity here, and I personally don't really grade them. It's for me, it's either paresis or paralyzed in unilateral, bilateral. But if you want to, we always like to grade things in vet med, as we should, to make it more objective. So there you go. Unilateral versus bilateral, paresis versus paralysis. Paradoxical motion, I was kind of alluding to before. You can have this because of flaccid cartilage. The vocal cords and mucosa are blown apart with expiration due to negative pressure created at inspiration. So the airway is trying to move, but because of the force by which it's trying to move, it creates this like fluttering or paradoxical motion where during inspiration it closes, during expiration it opens, and that which doesn't make any sense, right? It's paradoxical. So just keep that in mind too. Don't let it confuse you. Just think about what the dog is doing and then how deep you think the dog is. Yes?
Do you usually give Dopram?
So the question is, you give Dopram, which stimulates breathing. I do. I have given it before. So I'm usually using propofol just to effect. I'm titrating propofol to be able to look at the oral exam without getting bit, and also to help stabilize the dog if they're coming in really in distress. So if I feel like I gave too much propofol, I either can wait for the propofol to kind of get out of the system, or you can give some Dopram, doxapram to stimulate the breathing. And so whether you have it in your facility or not, and whether it's worth getting is up to you. But yeah, we'll administer doxapram for these dogs to help stimulate their breathing. Other things that help too is you can kind of irritate the dogs. Put your finger in their ear. You can mess with their tongue. You can gavage their chest. Try and get them to wake up more and stimulate them so they start breathing for you. Here's a picture of somebody trying to perform a scope. You either perform it through the nasal cavity or you can get really fancy in the oral cavity and look. Most of us are just going to use a laryngoscope and look. And that's the extent of it. We don't really need to do all the fancy stuff, but you can if you want to. This was a video of one of my friends has a thing on her retinoid that was causing paralysis, but I guess is it doing anything? There you go. So that's a human being's larynx, and there's some nodule or something that's affecting her. There. So she has a nodule here and here, and it's from just like probably talking too much or something. Okay, X-rays, radiographs. That's my friend Joya. She's a derm vet on like Disney show. So radiographs are used, as we spoke about before, to look for bronchopneumonia, for example. They can come in with pneumonia or they can develop a post-op. And so an incidence of 8 to 9% on pre-op rads, megaesophagus 11% pre-op, and then with any severe acute or peracute upper respiratory obstruction, you can have non-cardiogenic pulmonary edema. So that also you want to rule out as well. This is meant to show the cartilage. A lot of these older dogs, you can see that there's calcification of the cartilage of the larynx, the hyoid apparatus. So that's just to to show you that it's there. The other benefit to seeing the mineralization is it does make the cartilage more brittle, and so if you're trying to perform the tie-back surgery, those dogs may have a higher risk of either suture pull-through or the cartilage fracturing, either by your hands or just from motion post-operatively, it can fracture. So I warn pet owners about that if I know ahead of time. But you can either palpate the larynx and feel that it's kind of firm, or just preemptively warn the owners, hey, cartilage fracture is a risk. And this is just to show, just again, diffuse megaesophagus. If you do find pneumonia, pre-op, like do you cut them or not? And if the dog is stable enough, you can manage the medication and treat the pneumonia first. That's obviously the ideal scenario. And you can use whatever medications you want. I'm going with at least Clavamox, maybe Clavamox and Ventral, but whatever your cocktail for pneumonia is. If they can't wait, then unfortunately they're going to go under anesthesia and be cut at the same time they have bronchopneumonia. It's client communication. You warn them that it's unfortunate, but we don't really have a choice. So just keep that in mind too if you're cutting these cases. But ideally, you'd want to resolve the pneumonia before cutting them. And then a variety of other diagnostics that a lot of us are not going to perform, but just to give you a sense of how thorough these workups should be, and these are all in your proceedings as well. But these are muscle nerve potentials, measuring the functionality of the EMG, electromyography, which if anybody has an EMG, it's going to be a neurologist, and I don't even know if a lot of them even use it that much anymore, but I've never performed one. I just know this is what they look like. So medical management is going to be anything that you're comfortable with, right? The goal is if the patient's coming in distressed, you want to capture the airway, you want to lower the inflammation. If they're coming in hyperthermic, you want to try and lower their body temperature. So a lot of us are going to use some sort of sedation drugs of your choice. Most times they're coming in, they're really distressed. You might want to give something subcutaneous or IM and let them sit for a little bit, or if you can have IV access, then ideally something given intravenously, the way to go. And then as you're sedating them to try and capture the airway, you can look at the airway as well and diagnose the condition right then and there. So typically these pets come in to the ICU in a larger facility, and as we're sedating them, we're going to perform the laryngeal exam. And so usually they'll have the surgeon there while you're sedating them, so you can have the surgeon look at the airway while the ER doctor is stabilizing the pet, and then someone's going to talk to the people. And if it's a LARPAR surgical condition, the surgeon can go talk to them. If it's not, then ER can go talk to them. But regardless, you're going to capture the airway in those pets that are unstable and sedate them. I'm going to use, again, propofol, typically, if I can get IV access, intubate them, diagnose the condition. And then, whether or not you're going to perform steroids, depending on when you were taught what steroids you use. But I'm a fan of them. I think it's great, and especially if you perform a laryngeal examination and they have a ton of erythema from the arytenoid cartilages because they've been slamming into each other and causing all this laryngeal edema. So you want to try and calm down that inflammation, and steroids can help with that, but it depends on kind of what school of thought you're part of. And for anybody who's seen my talk on brachycephalic syndrome, similar idea here. So, these dogs may or may not be coming in fasted for you, right? If they're coming in with a crisis, respiratory crisis, they may have food in their stomach, and so if I'm getting them ready for anesthesia, I'm probably going to give them not only Cervinia pre-op, which a lot of people are using that as part of their pre-medication anyway now, but I'm going to give them a dose of Reglan to help metoclopramide to help with gastric motility, get that food moving. I do also like metoclopramide post-operatively as well. I will put them on a CRI of metoclopramide. I think it's cheaper, it's more effective than giving it like TID, IV, and I'll put them on a CRI of metoclopramide. I think it's great. I don't have any evidence to back that up. That's what I do. And the Cervinia can be given as a pre-med and then post-op to prevent nausea. Whether or not you're going to perform antibiotics or administer antibiotics on LARPAR dogs who don't have pneumonia, I don't know. It's up to you. It is a surgical procedure that is it's invasive. Obviously, it is sterile, and the question is with this day and age with antibiotic usage, is it overkill or not? I would say if you're going to use antibiotics on LARPAR cases, then I'm typically either going to do Convenia. If that's give the injection, it lasts 10 days or so, and that's great because you want to minimize oral medication for these dogs. Otherwise, something like simple cefpodoxime, so that's once a day, that's great. Of course, if they have pneumonia, different story. You're going to treat with antibiotics, and you can use whatever antibiotics you feel is appropriate for pneumonia. But if they don't have antibiotics, if they don't have pneumonia and I'm going to use antibiotics on them, I want to minimize oral medication on these dogs, right? Because we all know post-operative bronchopneumonia is the biggest killer of these dogs, and so whatever we can do to minimize vomiting or regurgitation post-op. But I am using antibiotics on them prophylactically. I can make the argument that maybe they don't need antibiotics post-op if they don't have a pneumonia, so kind of up to you. The reason why I'm doing it is because they're older animals. Their immune system is not as great, and if they're coming to me in a respiratory crisis or in shock, then that amplifies their immune system dysfunction, and so I'm going to give antibiotics for them. Now does the course of antibiotics post-op help prevent pneumonia? I mean, probably not, I would say, but who knows? Who knows? Then surgery. So a ton of different options for surgery. Most of these we're not performing. These are just, it's in the literature, and so I have to make you aware of them, that they exist. Most of us are going to perform the tie-back surgery, the arytenoid lateralization, but there's a whole bunch of options depending on the scenario and your experience level. It says nobody here cuts lower pars. I imagine probably most surgeons you're referring to are going to perform the tie-back surgery and are only going to use these things if indicated. But this is the tie-back surgery here. So you're literally suturing the arytenoid cartilage to the thyroid cartilage. That's the point. And you're creating a permanent opening of the vocal cords of the arytenoid on that one side. It typically is whatever side the surgeon is comfortable. So most right-handed surgeons are going to perform a left tie-back, and you're only going to do the one side, and the second side is only done if the first side fails, and that's typically how you're going to perform these. So yeah, a permanent suture. One usually applies two, but a permanent suture and creating a permanent opening. And you tell the pet owners it's not ideal, right? You can't fix these dogs with underlying it's idiopathic or neuromuscular disease. They're not going to be normal, right? They're still old dogs at the end of the day, so they're still going to be older geriatric dogs, so we're not creating a puppy out of this dog, and you still have one side that's paralyzed, and you're creating a permanent opening on the other side, so they're still going to expect loud breathing. They can't go swimming. You have to change their eating habits. All that stuff still has to be explained to pet owners so they have the expectation of what they're going to get back home to them when this dog goes home. So we'll go into these procedures just briefly, just so you have an idea of what they look like. The ventriculochordectomy is a removal of the vocal cord, including the ventricle on this side. Now, the ventricle is like a gutter that's there, and so I don't really even see it in this drawing, but here they are removing the vocal cord, and so you have this, and that's all that is. I've never done one. The downfall to this surgery is laryngeal webbing, which is scarring. And so any time you mess with the arytenoids in this fashion, you're prone to getting scarring, scar tissue. It's called laryngeal webbing. And that recreates the problem. And then you have to go back in and remove that. And so it's a pretty crappy scenario in those cases. That's why this is really easy to perform, but it's one of those things where you worry about scar tissue formation. I only perform this if for some reason the tie-back fails. I do the other side, it also fails, then this is what I have to do. You can get even crazier and just remove more of the vocal cords, so you're now including the arytenoids as well, and so you're chomping out this entire section here to create a permanent opening. Here's I mean, it just sucks. It's just not great. But you do to me, these are salvage procedures. You do these because the tie-back either are not options because you're not comfortable doing them and nobody else is going to do them, or the owner can't afford a surgeon, or there is no surgeon, or it's a Hail Mary because the tie-back has failed, and so you perform a partial arytenoidectomy in those cases. So chomp out of the arytenoid. This thing's insane. This is the ventral portion of the larynx here, where you create this Tetris-shaped incision, and then you move one section of the larynx, the hemilarynx, cranially, which I guess offsets the glottis, and so it creates it creates a larger opening that way. I've never seen it done, and And that's it. We just had to learn it for boards. So there it is. It exists. I don't know who would ever do this. It's crazy. And then this is really dramatic. So a partial laryngectomy. So you're removing a substantial portion of the larynx on one side. And I've only seen this done for neoplasia. You know, if you have an invasive cancer, I helped a surgeon perform one of these. It's a crazy surgery and a lot of bleeding. And the dogs typically they probably have to have a permanent tracheostomy, probably. But I don't have enough experience with them to comment on it further. It's just crazy invasive and, again, a Hail Mary. And this gets even crazier here, where you have to remove a portion of even more of the larynx and then reconstruct it. So, again, these are typically cases that I've only known to be done for tumors. But it's an option if you need to widen the laryngeal glottis. But I don't know anybody who does this for LARPAR. But I just wanted to be thorough and show you that you can do some crazy stuff. Oops. And this is a full-on laryngectomy where you have to have a tracheostomy. So you're removing the entire thing, and now you have to have a permanent trach. So, you know, good plug. No one's doing this except for like cancer or severe trauma, as far as I can tell. Somebody have a question?
No, you answered it. Sorry.
And of course, it's going to have a whole host of complications with it, mostly related to the permanent tracheostomy. You have to have the right case and the right owner, and you know all that. Okay. So anyway, so tie back. So arytenoid lateralization. There are even different permutations of this surgery that we won't go into too much detail with it. I just want you to be aware of it. But there's some cool things that people do. The titanium thyroplasty implant, that's pretty wild to place an implant to replace a larynx. I don't, again, these are in the literature, so whether or not they're practical or not is a different story. A minimally invasive keyhole, which I don't know why you would, but I guess you can get pretty good at these and do smaller incisions. Video assisted. You know, video assisted, actually, this is pretty cool. So if you're going to perform the tie back, you have to make sure you did a good job. And it'd be great to have an internal medicine doctor there with a scope looking at your repair as you're placing the suture for the tie back, to be able to watch what the dog's still intubated, to make sure you're not penetrating you're not going through the cartilage and even penetrating the endotracheal tube. So, and then of course when you place your suture, to make sure you're opening up, you know, wide enough, right? Make sure it's actually functional. So it'd be cool to have a laryngoscopy present as well. And then there's different permutations, again, that are detailed in lots of detail in your notes, but these are more for the surgeon to decide. You know, are they going to disarticulate the junction of where the cricoid cartilage meets the arytenoid cartilage? Are they going to disarticulate where the cricoid cartilage meets the thyroid cartilage? So this is referring to here. So this is the cricoid cartilage here. It articulates with the arytenoid cartilage and with the thyroid cartilage. So if you need more room as a surgeon to try and fit the suture through, or to make sure that your anatomy is correct, because these dogs do have really meaty larynxes that are also brittle with calcification, maybe you need to disarticulate the joints to do that. And the fear with doing this is that you may create more of an unstable situation, because those joints are there for a reason. And so you have to decide, is it worth it or not? Do you transect the cricoarytenoides dorsalis muscle? You know, and so that muscle is going to sit right over here. I don't have any way of not dissecting it or not transecting it. I mean, in order for me to be able to see the thyroid cartilage, I'm going to be dissecting here, freeing up the muscle from the cartilage so I can see the thyroid cartilage, and then that gives me access to the arytenoid. There's a sesamoid band in between the arytenoid, so it's ventrally, it's below here, and I have never had a reason to transect it, but that's an option to create more freedom with the arytenoid. There's different approaches. You can do a ventral approach, oral or lateral approach. I've only done lateral. I've never seen these two approaches done. You can do bilateral versus unilateral, which you should never do bilateral unless you have a very good reason to. And then, you know, do you place the suture between the arytenoid and the cricoid, or between thyroid and arytenoid? So it kind of depends. So I do it based on anatomy, what's most likely. So here's a cricoarytenoid lateralization here between the cricoid and the arytenoid, but you can also lateralize it with the thyroid cartilage instead. And then how tight you tie your sutures. There are studies on all this stuff that are in your proceedings, because you can imagine, unless you're actually measuring suture tension, which I never have, then you don't want to not do a tie back aggressive enough. We don't want to be too aggressive either because of aspiration pneumonia. So it's Otherwise, you're just going based on feel and just years of experience of doing it. And this is an intra-op picture. This is a nice one. I mean, this is the cartilage like really dissected away, and it's a perfect picture. But in reality, it's fat and bleeding, and you're trying to palpate through all this tissue because you can't dissect enough, and so it can be quite difficult. Which is why I say practice on cadavers if you're going to dive into the surgery to make sure you're comfortable with the anatomy there. It's always a disgusting mess when you're doing it. And this is using a scope to make sure to see. I can't position you on the anatomy here, but you can kind of imagine there's like a suture I guess here. Maybe this is the point of a needle, and you can try to visualize what you're doing with the scope, which is that'd be cool if you have that ability. The shaving for the dog, so this is lateral recumbency, muzzle, cranial's over here, caudal's this way, here's ventral, and so you have this big meaty neck that you're going to dissect through, and from there you go through, and this is what they look like. It's just and so in this picture here, this instrument is pulling on the rim of the thyroid cartilage. So it's going to be this portion here. So they're taking the lip here and pulling it back towards the surgeon in order to try and expose the arytenoid. And so this is what they're doing here. Not a great picture, but this is how it looks. It's like hamburger meat. And then if you're looking intraorally, you want to make sure you did a good job. You're going to see here it is before surgery and here it is after surgery. Nice tie back here. Now, I mentioned before that your suture can go through the arytenoid. Remember, the surgeon is out here somewhere, right, left side, if they're a right-handed surgeon. So the suture's going to come through, and you don't really care if you go through, although you prefer not to. But if you do go through, you don't want to snag the endotracheal tube. And so what I'll do is I'll pass the first suture and pass it through. And before I make my first tie for the tie back, I ask my assistant to move the endotracheal tube back and forth and see if my suture moves. And then the same thing with, I'm going to place 2 sutures, so the same thing with the second suture. And I'm probably using 0 proline for these. But that's how you know. And if you did snag the endotracheal tube, then you have to, of course, start over and then probably need a new tube. And so, and the biggest complication I see with the incision, with closure, is seroma. So you got to close it in multiple layers. They're going to be breathing, and so there's no way to stop that motion of your surgical site. And they're older, meaty dogs, so you need to have multiple layers. A seroma is very annoying, and you want to close in multiple layers. And I have a hard time even making these incisions look good because there's so much loose skin there, and they're just old dogs that it's just not meant to be pretty. What else can I say about this? Oh, and so once you pass your suture, you didn't snag the endotracheal tube, pass your second one, you didn't snag the tube, tie it, lavage, and then you can either decide then, do you want to, before you close, do you want to scrub out of surgery, extubate the dog, grab a laryngoscope and look at your work, and then re-scrub back into surgery, or do you want to finish the entire surgery and then evaluate post-op? Because obviously, if you evaluate post-op and you're not happy with it, you got to go back, re-scrub, open your incision up, and do it again, right? So I typically, before I close the incision, I place my 2 sutures. I'm happy. I scrub out of surgery, extubate the dog, take a look, and then scrub back in and close the rest of the surgery. That's my preference for it. I don't want to redo the whole incision. I'm sure there are plenty of surgeons out there who have the confidence to say, no, it's good. I know it's going to be good, so let me just finish this up and then I'll look. Which, fine, fair enough. But that's what I end up doing. It's annoying, but it's what you need to do. Because these surgeries can be very, very frustrating if you have to keep passing new suture repeatedly because you're not grabbing the right tissue because you're trying to not be too invasive, but it's also a mess in there. So I don't want to turn you off of doing the surgery, by the way. I'm just saying, get a cadaver and practice first. That's all. If you want to start diving into it. If you see enough of these surgeries where you can't have access to a surgeon, then maybe it's worth practicing. Yes?
Are you doing a full thickness bite through or just partial?
You're trying partial thickness, but it's all based on feel. I have no way of knowing unless you have somebody watching you orally while you're passing it. So, but it's a partial thickness, yeah. At the end of the day, really, I'm trying to be as aggressive as I can because I just want to make sure I grab the right structures and then perform a successful tie back. Complications, the most common, pneumonia. And this number is going to go towards 90 to 100% if you're performing a bilateral tie back. So bilateral, again, unless you have a really good reason to, you're not performing a bilateral simultaneous. You might have to do the second side later if the first side fails, but again, that's not really bilateral, right? It's a staged procedure. So pneumonia with unilateral is 0 to 33%. Bilateral, it's going to go up to the 90s, so you don't want to do that. This is an example of scar tissue. So here's a dog that had a partial retinoidectomy, and you have all this pink stuff here that's climbed in there, laryngeal webbing. So that's the problem with that. Coughing post-op, revision surgery. Well, coughing, first of all, so this is again a matter of lifestyle change. You have to tell these pet owners, no more swimming, ideally no neck leads. You're going to raise the food bowls. You're going to minimize the dust from the kibble. So you're either going to add in water to the kibble or change over to canned food. And that's the whole lifestyle. If the dog eats too fast, slow down its eating. You're going to implement these changes because their airway is not normal. They have a permanent opening. They're at lifetime risk for pneumonia. They're never going to be a normal dog. And again, they were old to begin with, so it's not like you have to make sure the owner understands. You're not reversing the timeline here. They're still old dogs with problems, and now they have a permanent opening. So, are you going to see coughing? Maybe. Are you going to see a change with phonation? Maybe. But it's better than having a dead dog, because when you came into me, the dog was critical, right, with the upper respiratory obstruction. So maybe some coughing. Revision only occurs either A, if you have a seroma of the incision, you didn't close all the layers appropriately, or B, the surgery fails. It usually fails because the cartilage fractures, the suture evulses, or your suture breaks, typically. And it may not be your fault. It's just the way the dog's anatomy is and constant repetitive motion over time. So if it does break down, you should have a recrudescence of the clinical signs, and then options for the pet owner. Can we do medical management, or are we going to reoperate? It's up to you and the owner to discuss that and decide. Hematoma formation, laryngeal webbing, seroma, dysphonia, GDV. I mean, this is the same subset of dogs that have GDVs anyway, and in theory, any condition that's going to have respiratory complications to it can create bloat and GDV. So, and respiratory distress. Complications are a potential lifelong death, 0 to 14%. I mean, the biggest reason why I see death either is because they euthanize, they don't want to do surgery, it's an older dog and all these problems, or it develops pneumonia later on, they're like, I'm done with it, or it fails the first side, they're like, I'm done. And so those are typically what happens with these dogs. Pharyngeal dysfunction, this may be more of a function of neuromuscular disease if they're having other issues with either swallowing or airway transmission. Overcorrection, again, hard to say whether or not you're overcorrecting or not, I guess. I mean, because if they developed pneumonia, do you know it was your fault? It was too much tension, or was it the dog's just inherent issues? I don't know. But certainly, if you repair bilateral, the chance of pneumonia is really high. Prognosis depends on a lot of things, but this is also seen with lots of other surgeries anyway. But if they have respiratory tract problems, of course, they're going to have a worse prognosis. Pneumonia going into it is going to be a worse prognosis. Concurrent esophageal disease, so remember megaesophagus might be in some of these dogs. Keep in mind too, you can see megaesophagus, by the way, when dogs are under anesthesia or have been fasted, right? So reflux esophagitis can cause megaesophagus. That's not the same thing as a neuromuscular disease. Can you differentiate that? Can you differentiate those two things? Probably not, but if the dog had neuromuscular disease beforehand and has megaesophagus, it's probably megaesophagus. If they did not have a history of neuromuscular disease and they were fasted or under anesthesia, maybe that megaesophagus is transient. It's related to anesthesia or sedation or esophageal reflux. So just keep that in mind too. You can see megaesophagus in normal animals just because they're fasted, they have esophageal reflux, they're sedated. So anyway, a real concurrent esophageal disease plays a role in prognosis. If you need to place a trach tube, obviously these are dogs that are coming in more compromised. If you have to find a way to bypass the airway because they're struggling to breathe and for some reason you can't capture the airway, then a temporary trach may be the way to go. If they have neoplasia, of course, neurologic disease. The presence of neurologic disease does worsen the prognosis. As you can imagine, of course, any more comorbidities can cause worsening of the prognosis. The larger dogs, the obese dogs, let's say, older dogs, surgeon experience, all these things play a role in prognosis. I have these all in your proceedings as well, as far as what the literature says. But the whole point is, when you talk to owners, they have to just understand that there's a lot going on. Older dog, lots of problems. We have to decide now, are we operating or not? And if you can get away with medical management, then great. I'm a fan of the surgery. I think it works really well. It's just a matter of having the right owner, because these are always going to be older dogs. So you want the outcome to be consistent, immediate, and effective, of course. Trach 2, we already talked about. The only time you ever have this either is if you have to bypass the upper airway, or if you have a permanent trach because you performed a laryngectomy, but I don't think anybody would. And then clinical signs post-op. A lot of them have signs. I mean, yeah, because just the changing in the voice and the coughing is going to be a clinical sign. So they're not going to be normal dogs, but they have an improved quality of life. Median survival 8.5 months. Average survival 12 months. So client communication is key. The clinical signs of this condition are pretty classic. You want to screen the patient. You've got medical management for those dogs that either are mildly affected or owners that don't want to perform surgery. Maybe you can get away with medication, and also in preparation for surgery. And then surgical intervention is going to be the treatment. But again, keep in mind it doesn't really cure anything. It's like blocked calves. It's just a palliative measure to try and prevent a crisis down the line. This is how you can reach me. And if you have any questions, yes.
I know you're a surgeon, but can you speak a little bit to medical management for dogs that are not going to have surgery?
Yeah, so it would definitely be all the same information as post-op recovery. So changing the kibble, no neck leads, slowing down their eating, raising the food bowls, for sure. You want to keep them cool environments. They don't overheat and start panting and stuff like that. That's going to create a crisis for them. We want to prevent anything that's going to create stress in their life in general. And then medication-wise, you can either go the route of NSAIDs or steroids, prednisone. I'm a steroid fan. I'm fine with steroids, but different schools of thought with that. But something anti-inflammatory, low-grade anti-inflammatory dose of prednisone would be great. And then any kind of sedation cocktail you want to use. Now there's lots of options, but gabapentin, trazodone, tramadol, acepromazine are all good options. And the goal here is it's like managing collapsing trachea dogs. You're trying to find the right cocktail for that dog to not make it a zombie at home, but to also be able to alleviate the clinical signs and prevent a crisis. So it's going to be some trial and error with the right pet owner to decide what's working, what's not working.
Can I have a follow-up? Any thoughts on doxepin?
I'm not familiar with that one. What's doxepin?
There's some stuff online, and it's like I had a client that went deep down the rabbit trail. And said doxepin is like an over anxiety antihistamine kind of a weird drug that.
So we used to use it a lot in birds for feather picking. I think it's an antihistamine, but there are some write-ups on it.
Oh, cool. Yeah.
Didn't know if you had any experience.
Yeah, no experience with it, but yeah, anything that has some sort of sedatory effects would be great.
And I felt like the dog that I used it with, it's pretty safe. So it's kind of like if they want to try it, sure, it might help.
Yeah. Yeah. The general class of medication we're looking at here, besides lifestyle changes, environmental changes, is going to be anti-inflammatory and sedation, and that's my go-to with it. Those combination of things are what you're trying to implement. Yeah, I don't think I know. I think somebody told me there's some what do you call them, herbal medicine doctors, the vets who holistic vets. Apparently some of them have pretty cool, successful cocktails for this stuff too. So it's an option for people who want that kind of trajectory. You can consider that too, if there's anybody in your area, yeah. But, and then, I'm a fan of weight loss, in dogs, obviously you want to get them lighter. So obesity can play a role in putting more pressure, making them breathe harder overall anyway, so. Yes?
I should have asked this in your brachycephalic lecture, but have you heard about the emergency palatopexy procedure?
Palatopexy? No, I have not.
Yeah, there's like a paper about the dogs coming in and heat stroke and respiratory crisis with elongated soft palates, and just doing a quick pexy of the palate, the soft palate.
Are they rolling it?
Like bringing it cranially and pexying it to the hard palate.
Oh, cool. So a palatopexy where you take the elongated soft palate and like a brachycephalic dog, pull it cranially, and then suture to the hard palate. That's pretty cool.
Just as like a temporary help.
Temporary?
Like in the ER setting.
Oh, that's very cool.
Yeah.
I'm almost wondering I guess temporary, huh? Because you're adding another layer of tissue in the oral cavity now, so that's going to be a problem. But at least it won't creep into this. Into that. Wow, that's cool. Yeah, no, I have never heard of that before or performed it. Cool, thank you.
Yeah.
Anything else? Yes?
So would there ever be an indication to do a combined procedure where you do tieback on one side, maybe a ventral cordectomy on the other side?
Yes, the question is, do you ever combine procedures, maybe a tieback on one side and a ventriculorectomy or a retinoidectomy on the other side? Yes, but I would treat it the same way as performing a bilateral tieback. You have to have a good reason to, you know? I have done that before. I've done it where I did a tieback on one side and it just sucks, and I kept retrying and I can't get the opening, and so, it's a little bit more open, and so then I'll do a retinoidectomy on the other side. Not ideal, but yeah, I've done that before. It all comes down to whether or not you're happy with the opening that you're creating. Yes, yeah. But you have to have a good reason to, I would say. Because the chance of pneumonia goes up so high when if you open up both sides. Yes, another question? Yes.
I feel like a lot of times when I meet these guys on emergency and a crisis, their history is like, yeah, my GP stopped for a couple of years, this is what we were dealing with, they said to keep an eye on it. Is there a reason not to pursue these guys earlier? So like, if there's a progressive heat and exercise intolerance, is that enough to recommend surgery, or should we be waiting until they have a crisis?
Yeah, so the question is, a lot of times general practitioners are treating these dogs medically or sort of monitoring at home for years as their lower part maybe gets worse, but it's insidious. Is there a reason not to treat them earlier with surgical intervention? No, I'm all for earlier intervention. It's just a matter of documenting if they actually have laryngeal dysfunction. So you have to sedate the dog and look in there and decide, okay, is this paresis or paralysis bad enough that I can advocate for surgery? You always want to perform surgery in a patient who's not compromised, right? It's the reason why you cut a splenic mass before it becomes a hemoabdomen. Besides the fact that, if the malignant has more time to metastasize, but you'd rather perform a splenectomy in a controlled setting at noon as opposed to 3 in the morning with hemoabdomen and DIC and VPCs and that mess, right? So if you're able to have a discussion with a pet owner to at least let them allow you to look at the airway and document some kind of laryngeal dysfunction, then I'm all for it. I'm trying to think of any reason why because you don't want to, as long as you can prove that there's some sort of laryngeal dysfunction, I'm all for it. Because the earlier you can get involved, the better, I would say. It may come down to similar to what we were talking about earlier with total hip replacements, where the longer that implant in that dog, the more chance it has to fail over time. But, again, you can't control that. But yeah, I'd be okay with it as long as you can prove that there's a dysfunction. Yes?
In like a situation like that where it's mild, would you prefer medical management first and see how long you can kind of go and just...
So the question is, if you do document that if it's like mild, do you prefer medical management? And that's what most of us do, right? Most of us will not talk about surgery for a dog who's stable, otherwise doing okay, mild lower par signs. You didn't really diagnose it, but you're like, it probably is lower par. That's what most of us end up doing, is that. And so most veterinarians, most clients are going to push surgery unless you really need it. If you have a 3-year-old, again, back to black cat, 3-year-old male cat that's got some lower urinary tract signs, you don't automatically perform a peritoneal urethrostomy on them. You medically manage them, right? Because they're not in a crisis, they're healthy otherwise, and so you can make the case you do a PU now to avoid a crisis, but most of us won't. So we're going to medically manage it, and then we'll deal with a PU surgery later on if it becomes blocked and all that stuff. So most of us will do that, medical management. It just depends. It depends. It's all about client communication. You don't want to seem like you're being too aggressive because you don't know where the next 5 years that dog is going to be. He or she may always stay mildly affected and never need surgery. But how do you know? So it's about clear communication with the clients, I would say. Anything else? Thanks, guys. Thank you.